Dr. Waibel. So Dr. Kirk Waibel is a board-certified allergy and immunology physician. He's served in the United States Army, most recently as the Chief of Allergy Service at Brooke Army Medical Center and the allergy consultant to the Army Surgeon General before joining the civilian world and being one of the only physicians in San Antonio who is performing intralymphatic immunotherapy, which we'll talk about a little bit later, and also treating food allergies with oral immunotherapy, which will also be talked about tomorrow. But welcome to the stage, Dr. Kirk Waibel.
Laser.
That's gonna
Testing, testing. Can y'all hear me? Great. Well, again, I want to start with thanking the organizers for allowing me to speak, and we'll get the slides up here. I guess this is the time I have to tell a joke. But my kids say it's all dad jokes, so I can't go there. Great. So you have my email there, so please, you should have some PDF files that are linked to this talk. So if you don't see them or see anything on these slides you want, please feel free to email me. And of course, the topic of my talk is atopic dermatitis with some attention to these newer JAK kinase inhibitors, or JAKs. I don't have any disclosures. Just some objectives for me, hopefully to pass along to you in the audience is, of course, we want to recognize some of these clinical and immunologic features of atopic dermatitis. How do we even assess, diagnose, and treat these patients? And of course, understand the treatment options and what risks and roles they come with. So as was mentioned in a couple of the speakers already so far this morning, we know that atopic dermatitis is pretty much the most common chronic skin disorder in children, with a prevalence of 10 to 30%, but also mentioned it can occur in adults. Most of these cases you'll see in the pediatric population, usually in that first year of life. And fortunately for most of these cases, they're mild, they're going to resolve over time, but as you know, they can persist into adolescence, even adulthood. In the, I guess as was said, the more mature individuals in this audience, in the older literature, you'll see this term difficult to treat. And if you ever run across that, what it refers to is patients with atopic dermatitis who failed daily moisturizers and low-dose corticosteroids, such as 1% hydrocortisone or 0.05% clobetasol. So as you go into the different creams, just if you run across that, that's what it's referring to. There's also, of course, criteria out there. I don't want to go over all the points of the criteria. These should be some attachments for you, but there are major and minor criteria. There are lots of other tools that are out there from a lot of dermatology societies that help you classify it. But what you want to make sure is if you think it's atopic dermatitis, of course, make sure you have your differential diagnosis. What else could it be? So this is one other thing that it could be that presents with a very itchy eczema kind of looking rash. Maybe it has a little linear appearance to it, right? Don't want to miss that. Again, eczema happens in babies and toddlers. Maybe it's on the cheeks, which eczema can also be on the cheeks, but just more crusty looking, of course, on the scalp, different portions of the body, so seborrhea. And then you'll hopefully be seeing a fair amount of this, which is this sometimes itchy, although not necessarily, kind of chicken skin looking thing, often on the upper arms, but actually can be on the face, right? And we're talking about keratosis pilaris, so keep those in mind. And again, not to reiterate, but just to kind of highlight that the problem with atopic dermatitis is, again, this barrier loss. You're losing water. There's some newer studies that show the skin taping method is going to kind of achieve a lot of insight into this and potential therapy options. And of course, we recognize that eczema is probably one of the first stops on what I call the allergy train, or atopy. These children are going to be at increased risk for allergic rhinitis, asthma, food allergy. You can see the odds ratio there. And of course, they have a huge impact on their quality of life. You're not sleeping well, and that affects everybody, including the parents. When you see these patients, again, we'll go through some scoring scales briefly, but when you're assessing them and you're writing your notes, and I'm looking at our biologics coordinator, now we're really classifying them as mild, moderate, or severe. There's a number of validated scoring systems. I'll go over the IGA, but you also have the Eczema Activity and Severity Index, the Scoring Atopic Dermatitis, or SCORAD, and the Patient-Oriented Eczema Measure. I kind of like using them all in clinic, and I would encourage you to do them and include that in the first line of your note about your assessment, because that's going to be really important when people are looking at your notes about what treatment options you're choosing. And a lot of times this is, to me, it's a little bit of a self-reporting, but I give it to every parent and say, hey, fill this out for your kid, give it to the MA, let them do it before I even walk in the room. And there's a calculator there as well. If you want to do the SCORAD, there's different ways to do it. I just Google that, put in the little clicks, and then it gives me the SCORAD number. No calculator needed. So I personally like this IGA. It's a 5-point scale. To me, it's just the easiest to use. You can see the descriptions there, ranging from clear to really bad, evil disease. But what I got from a dermatology colleague in town is basically, if you see any oozing or any crusting, that fits this IGA level 3 or 4. And when you get to 3 or 4, we're talking about more moderate to severe, and that's going to impact potentially future treatment options. So of those treatment options, again, this should be attachment, so you can refer to it later. I don't want to go through it all, but there's different steps that we want to try to do, specifically lots of moisturizers. Baths are okay. Topical steroids certainly are going to be used. I did run across an interesting sort of comment, which is you give these creams to patients and parents, but are you educating them on how to do it? And one study found that parents weren't even sure how they're supposed to use these creams. You have the calcineurin inhibitors, pimecrolimus, tacrolimus, the Eucrisa, phosphodiesterase inhibitors. You can use oral. I've used some cyclosporin in patients. That seems to have helped some of these patients. And of course, as mentioned, phototherapy. And now, of course, the stage is set with these 2 lectures about the biologics and the JAK inhibitors. Before we get to those specific inhibitors, though, I thought it'd be value added for the audience to highlight what came up in our recent Academy meeting in San Antonio here. And basically, the experts in our field said we need to answer some really important questions about what we're doing with atopic dermatitis. And what they put together, a bunch of people, experts, they used a grade system. I don't want to go into what a grade system is, but they basically researched literature, looked at strength of articles, looked at conclusions and recommendations, and tried to make some opinions and recommendations for us as practicing allergists in the clinics and academic areas. So the first question which was asked is, what about these topical calcineurin inhibitors? Are they really helpful? Are they safe? And so at the end of all this grade system and deliberating, they felt that yes, they are effective, and perhaps even the 0.1% tacrolimus may be better than those class 6 or 7 corticosteroids, and actually is probably superior to pimecrolimus. So again, if you had to choose perhaps between Protopic and Elidel, maybe we're using the Protopic. How about elimination diets? Right? You have a toddler, an infant with really bad eczema, and we're talking about, right, are we going to skin test? Are we going to do some dietary elimination? And they really wanted to know what came of that. So again, they found about 10 studies that they finally used for this analysis. Just of note, in these studies, over 500 individuals. You can see some demographics here. Of course, we know that certain studies, if they use a certain demographic, may not apply to other demographics. And the endpoint that they are looking for the minimal important difference was a SCORAD change of 8.7. I'll just say that if you look at some of these studies, most of the SCORADs were under 25, which was interesting because that's a mild category. But because SCORAD can range from 0 to 103, but what they found was both these groups, whether you eliminate a diet based on testing or kept them on the food, there's probably not a statistical difference. So back to the, are we going to do food testing and elimination? Within this consortium of experts that came out with this conclusion was maybe there's not much difference at all. And why are we just blanket eliminating foods or doing testing to eliminate food? And as we've heard, food avoidance is not risk-free because that may increase your risk for future anaphylaxis. The third question was, well, how about immunotherapy? Many of these patients have comorbid disorders, atopic dermatitis, so perhaps in the more moderate to severe disease, there is some moderate certainty to the role of immunotherapy, but more mild eczema, maybe not so much. But again, realize these children or adults may have this coexisting comorbid issue, so it's not that they might not improve, it's just you're not doing it to treat their eczema with immunotherapy in the more mild group. Bleach baths, some of us have used bleach baths over the years. Again, perhaps maybe you're trying to pull out every possible therapeutic option. Maybe you want to consider that neck down soak and then rinsing it off. And then the last question was, well, what about these more immunomodulatory treatments, the biologics, the JAK inhibitors? And that's where the big question is, how do we really apply these? So again, this is very busy, but essentially on the external surface where you have these cell receptors, that's where the biologics are coming in, the monoclonal antibodies. And on the inside of the cell surface, that's where you're seeing your Janus kinase aspects. You're going to have these other molecules that are going to be targeted in the near future. I put a little yellow star for those drugs in the JAK family that have been approved, and we'll go over them. You could put a star here, but baricitinib is approved only in Japan and Europe. So why might you consider a JAK inhibitor? Well, you've seen all these interleukins and cytokines and other fancy things, and I don't know, there's a whole lot of things going on, so why don't you have a nice small molecule that can target a whole lot of things? Because a lot of these are going to be involved in the atopic dermatitis pathways. And you can see too, there's different JAK inhibitors. Just realize that most of the risk with JAK inhibitors historically has come from the pan-JAK inhibitors, JAK 1, 2, and 3, and they have a lot of issues. These new JAK inhibitors for atopic dermatitis are either dual JAK inhibitors or selective JAK inhibitors. I looked right before I came to this meeting, was this actually in publication? I didn't see it, but I thought it was a really nice, kind of easy to read handout about the benefits and potential downside of whether it's a monoclonal antibody or these newer JAK inhibitors. And as was mentioned, they're nice because they're very short acting, they're oral, but the concern is they come with what I would call some baggage. And so you're going to potentially need to have that discussion about that patient, their underlying risk factors, and how we're going to monitor you if we're going to start one of these medications. So of the ones that are out there, there's 3 of them. So one is ruxolitinib. It's a topical dual JAK inhibitor. It's nice. You can use it in, I guess, tweeners now and then above. You do have to limit the body surface area, but it is approved actually for mild to moderate atopic dermatitis, and you don't necessarily have to monitor labs unless you want to. Of the oral JAK inhibitors, you have abrocitinib, which again is a selective JAK1 inhibitor approved for 12 and older. It comes in 2 doses. And then upadacitinib, also again a selective JAK inhibitor, comes in 2 doses. And I'll just highlight, as probably my colleague will try to argue about potentially dupilumab versus this. They did show in a head-to-head study, which I thought was very interesting, company against company, that perhaps these JAK inhibitors are superior to dupilumab. However, kind of the superiority was at the higher doses. And the issue with the higher doses is you're going to have potentially more side effects. But it did have some statistical differences. But what, again, I've been able to research, and I guess for full disclosure, I don't have anyone on a JAK inhibitor. I should have asked the audience if anyone would want to raise their hand and they have a patient on a JAK inhibitor. There are black box warnings. But in terms of the very severe, what they call MACE outcomes, it's rare to none. But if you have an older individual or underlying known risk factors, myocardial infarction, other things, then you probably don't want to go there in these more at-risk patients. So again, the bottom line, and thank you for your attention for this talk, really think about the basics. Where are we starting with this person? Are they actually using moisturizers? Are they doing baths? Are they taking care of their skin as best they can? You know, there are allergy action plans for asthma, but have you ever given one for eczema? They're out there. So it's important to keep the parents involved, but it's nice that we have a lot more options to discuss with our patients. So if we have time, I'm happy to answer any questions, but thank you again.